Some people stay up late at night thinking about the meaning of life, or about life on other planets. In care management, other things keep us up at night. At the top of that list is the quality of clinical documentation and how important it is to our future. So sit back and let us tell you how we can work together. Your clinical documentation drives all the major measures of quality, severity of illness, risk of mortality, and clinical outcomes. These outcomes are used by Consumer Reports, U.S. News and World Report, and health grades to identify the highest performing hospitals. Let's look at how this works. Let's say you admit a patient to the hospital with a cough and fever. You diagnose the patient with pneumonia. He's in the hospital for 2 days, treated with IV antibiotics, and then sent home. Pretty simple, right? Now let's take another patient with the same admitting diagnosis, except this patient is on home oxygen for COPD. She's had a kidney transplant, and uncontrolled diabetes, and chronic systolic heart failure. During her hospitalization, in addition to IV antibiotics, she required transfer to the intermediate care unit where she was placed on BiPAP for acute on chronic respiratory failure. She required an insulin drip to control blood sugars and IV Lasix for acute on chronic systolic heart failure. She was hospitalized for 6 days before being discharged home. The second patient was obviously more complex and sicker of the two, had a longer length of stay in the hospital, and required more resources to care for her. So why does this matter, you ask? Let's imagine that these houses represent each patient's episode of care. When groups like health grades are comparing hospitals, they assume that every hospital can manage uncomplicated cases. What they want to identify are hospitals that are capable of managing the more complicated cases, yet maintain positive discharge outcomes. Now you're probably asking yourself, how do they know the difference? It goes back to 1982, when Medicare developed a system of measuring inpatient acuity for the purpose of assigning reimbursement. The outcome was the assignment of a diagnostic-related group, or DRG, to each patient. The DRG takes into consideration the patient's complications and their comorbidities, but does not take into consideration the actual resources that are utilized or the length of stay of the patient. So how do we distinguish levels of patient complexity? Let's go back to our two patients, each having the principal diagnosis of simple pneumonia. They would each be assigned DRG 195. But remember, one of our patients was sicker and required more complex care. No one knows the difference unless the differences are documented. And this is where you come into the picture. To achieve the most accurate picture of a patient's hospitalization, your clinical documentation needs to paint a crystal clear picture. All symptoms, medications, treatments, and abnormal labs must be linked to a diagnosis. Of all the diagnoses you have documented, some diagnoses are classified as complications and comorbidities, or CCs, diagnoses like hyponatremia or acute blood loss anemia. More severe diagnoses are called major complications and comorbidities, or MCCs, like myocardial infarction or encephalopathy. The CCs and MCCs are the building blocks of the DRG and ultimately reflect the severity of illness and risk of mortality of our hospitalized patients. So now let's go back to our two pneumonia cases and see how this works. Our first case would be assigned DRG 195, or simple pneumonia, without an MCC or CC. No secondary diagnoses were documented. They just had symptoms of fever and cough, received IV antibiotics, and went home. Case number 2 also had pneumonia, but also had a number of secondary diagnoses. They were status post-kidney transplant, which is a CC. They had uncontrolled diabetes, which is a CC. Acute on chronic systolic heart failure, which is an MCC. Acute on chronic respiratory failure, which is an MCC. Case number 2 would be assigned to DRG of 193, which is pneumonia with an MCC or CC. The first pneumonia case without an MCC or CC would have a lower reimbursement, and the expected length of stay would be 3.5 days. Case number 2, pneumonia with an MCC and CC, would have approximately 3 times the reimbursement compared with the simple pneumonia, and the expected length of stay would be 6.3 days. Should a patient with pneumonia only have one or more cc's and not any MCCs, they would be assigned DRG 194 with a reimbursement somewhere in between the other two DRGs and an expected length of stay of about 4.7 days. So you are the home builder, and what you document determines reimbursement, severity of illness, risk of mortality, and ultimately the national ranking of our hospital. We do not want you to stay up late at night pondering the completeness of your documentation. The Clinical Documentation Improvement Team is here to work with you to assure that your documentation reflects your hard work and the exemplary care your patients receive.